Welcome to another MRCS OSCE teaching video. Today we are going to be talking about obstructive jaundice, a topic that comes out more often than not in MRCS OSCE.
Let's proceed. What is bilirubin?
Bilirubin is a bile pigment, produced by the breakdown of heme from hemolyzed red blood cells to biliverdin, which is, in turn, converted in macrophages to bilirubin.
Where does this breakdown take place?
This happens mainly in the reticuloendothelial system and also within the circulation.
How does bilirubin get excreted?
Unconjugated bilirubin produced in the reticuloendothelial system enters the blood, bound to serum albumin, and is then transported to the liver. Hepatocytes conjugate bilirubin with glucuronic acid, and the enzyme UGT. Conjugated bilirubin diglycuronide is secreted into the small intestine, with bile, in micelles. It is deconjugated to urobilinogen by large intestine bacteria. Urobilinogen may either be further reduced to brown scobilinogen and excreted in feces, or reabsorbed and transported to the kidney to be excreted as yellow urobilin. Small amount of conjugated bilirubin enters plasma.
What is jaundice, and how would you classify it?
Jaundice is the visible manifestation of hyperbilirubinemia, usually in the skin, sclera and mucous membranes. This happens at concentrations greater than 35 to 45 micromoles. Jaundice can be classified as prehepatic, often hemolytic, hepatitic and posthepatic, also known as obstructive.
Please elaborate on some causes of obstructive jaundice.
The obstruction can be a complete one, in cases such as tumors or a ligated common bile duct. A common bile duct stone or a choledocholecyst can cause intermittent obstruction. Strictures of the common bile duct, chronic pancreatitis and cystic fibrosis can cause chronic incomplete obstruction. Trauma, sclerosing cholangitis, cholangiocarcinoma can cause segmental obstruction.
How would you manage somebody with obstructive jaundice of unknown cause?
I would initially manage the patient using the ABC approach, ensuring good hydration, and if patient is septic, give appropriate antibiotics. I will then confirm the diagnosis using imaging. Abdominal ultrasound may reveal the presence of gallstones and intrahepatic or extrahepatic duct dilatation, as well as the level of obstruction. Ultrasound is also good at examining the liver for tumors, portal vein flow and possible pancreatic masses.
What is your next investigation of choice?
If no cause is found on ultrasound, a CT scan is essential to look for pancreatic lesions. ERCP would be my next line if CBD stones have been found.
What are the advantages and complications of ERCP?
ERCP allows good demonstration of ductal anatomy and the level of obstruction. It can also be therapeutic via sphincterotomy and stone extraction, balloon dilatation or stenting. ERCP, however, causes pancreatitis in up to 5% of cases. There is also a risk of infection and septicemia. Therapeutic sphincterotomy can also result in hemorrhage. ERCP also needs specialist equipment and endoscopists, which may not be universally available.
Finally, which other non-surgical intervention can be used to relieve jaundice if ERCP is unsuccessful?
Percutaneous transhepatic cholangiography with biliary drainage can be used in those cases.
Good, that's all the questions for this station. Please wait outside for your next one.
Thank you.
We hope that you enjoyed this video and that you will join us for the next one.